Good afternoon, everyone, and thank you for joining us today for our latest webinar. This one is on our recent research into open APIs in healthcare and the future of data integration, looking at data integration platforms and other platform players that are providing these APIs to enable new models of care and new care functionality. So, quick little bit about chlmrk Research. Our team is united by a core belief that effective deployment and use of IT is essential to modernizing care delivery and improving the care journey. We choose our research topics each year framed around what technologies we see as rapidly evolving and having that kind of direct impact on the care experience for all stakeholders. Our analysts monitor trends and developments in the industry with a focus on those technologies that are truly going to be transformational to how healthcare is delivered. And we do this through comprehensive, objective, high-quality research for busy executives. It is our way to help create a more informed, future-ready market of products and customers. And with everything going on in the world, it is our goal to create clarity in an uncertain time. Today's presenter is Brian Murphy. He has been with the company for quite some time, since 2012. He is an outspoken advocate for interoperability and has been really focused on interop and analytics for the past number of years, leading our research in those areas. He is a graduate of both Harvard College and Suffolk Law School, and when he's not thinking about health IT, he is a runner and armchair Boston historian. So without further ado, I'll pass it off to Brian.
Thank you, John, and thank you very much, everyone, for attending today. And thank you for those people who choose to click on the YouTube version of this. I guess in these modern times tends to be a somewhat larger crowd. We've got a bunch of things that we're going to talk about today in the next 40 minutes or so, after which we're going to open up the thing to questions. So if any questions occur to you at any point, please go ahead and enter them in the question and answer box. These are some of the stuff we've been looking at for really the last 2 or 3 years in terms of what's happening in the healthcare market generally with interoperability. I think as most people know, HHS issued a set of regulations that came out of the 21st Century Cures Act at the very beginning of our COVID-19 pandemic. And these regulations essentially said, thou shalt have FHIR standard APIs for certain kinds of healthcare enterprises. Now, for the most part, at least initially, these rules apply to providers, payers, and their vendors, but we really feel like these regulations set the stage to affect pretty much anyone who's involved in healthcare in a bunch of different ways. These rules really establish the idea that kind of API-based development and integration is going to be with us for quite some time. And APIs, in the sense that the word is used in these regulations, they make it easier for developers to get at the data they need to build their applications, especially as compared to the conventional methods that we've been using in healthcare for the last 25 years. We're talking about open APIs here. Open in this context means that anybody can find out about these. The documentation's online. Anybody can kind of read up and understand what they do. Open doesn't mean free of charge. The healthcare industry is relatively new to this idea of APIs, so the revenue models are not, are frankly undeveloped. Outside of healthcare, primarily in consumer markets, API revenue models are more developed. So there is, to some extent, a path to follow. But in those consumer markets, those revenue models happen to be very controversial at the moment. In the days before these rules came out, there was quite a bit of concern expressed by a bunch of different organizations in healthcare about whether there was going to be enough protection for patient and member privacy and security. And I would say that those concerns have only increased since these rules came out. So I feel like this is an unfinished aspect of this story. So with that, we'll kind of get into it. As I said, this webinar is, most of the content here is going to be derived from the market trends report that we published a couple of weeks ago, which is available for anybody who's interested. And the report provides quite a bit more detail than we're going to be able to get into here. I want to step back for just a moment to put this particular discussion in the wider context of interoperability in healthcare. This graphic is just kind of a very high-level summary of the range of different capabilities that are in the market right now. Today, and for the report that this webinar is based on, we're talking about the extreme left-hand column here, data-oriented APIs. APIs that make data about a single patient or a member accessible to, for the most part, transactional applications. The vendors that we talk about in this report build APIs under agreement with a payer or a provider and then offer that data as a service. Developers then get access to the data that that vendor has, and they then have access to scores or hundreds of different organizations who may be behind that API. The other four columns, and these columns are in no particular order. We are planning market trends reports on each of these, and this is just a sequence in which we're going to publish them. Data aggregators, they combine data from multiple organizations to produce data stores that are usable for population level applications or reporting applications. Interoperability infrastructure products focus on specific, somewhat narrow processing and data related requirements. Many of them are used by the vendors that appear in this report. They tend to be primarily software vendors. In other words, data is not necessarily their product. Their product is really the ability to manipulate data. Messaging products are ubiquitous in this market. They let individual users and organizations communicate directly with each other, usually with some kind of a data payload that's of interest to the recipient. And finally, patient matching vendors are almost a special case of the interoperability infrastructure. Vendors, they, as the name implies, they link records for a particular person across applications and organizations. Why are we talking about APIs now? APIs are not new in any real way. They've been around since the late 50s. Most of the conventional and the widely used integration methods that most people can rattle off here, things like HL7, IHE, X12, they use APIs as well. But something has changed. So healthcare, as I think everybody knows, is being buffeted by change and uncertainty. In addition to COVID, consumers are restive and dissatisfied with healthcare, and they're looking for better, less costly ways to access the healthcare system. They want to be able to interact with the healthcare system in the same way that they interact with a lot of the other organizations, like banks and whatever it might be. At the same time, the whole trend away from fee-for-service-based healthcare is continuing even through COVID. Technology has really changed. As I said, APIs are not necessarily new, but what is relatively new is FHIR and REST-style APIs. FHIR is a way to represent any kind of healthcare data and use it in applications. It's been percolating since 2011. While the implementation experience is still relatively thin, support for it is very broad, and nobody is seriously looking at any kind of alternative. REST is more new in healthcare than FHIR. This approach basically delivered a development productivity boom outside of healthcare, particularly in consumer markets. And there's every reason to believe that it can deliver similar results inside healthcare. As I said already, government got into the act with the new rules. They also introduced penalties for anyone who withholds access to data unfairly or unreasonably. The feds are also, and one of the other things that kind of came out of the 21st Century Cures Act, people kind of gets lost in the shuffle. They've introduced this idea of a national level network of networks open to anyone that would provide a trust framework that would give organizations that, confidence to participate more fully in health information exchange, not coincidentally using APIs. This would not be the first national level network of networks that was proposed, but this one, APIs is one of the reasons that this one could potentially succeed where some of the others have failed. I'm not going to spend a lot of time in this slide. It gives you some of the probably the most significant events that have occurred in what is shaping up to be a roughly 15-year timeline from the beginning of FHIR development back in 2011 to a really full, complete rollout of FHIR and REST APIs by healthcare enterprises. So according to this, we're really only 2/3 of the way through. So just a couple words on the 21st Century Cures Act and the kind of what it means here. So in the run-up to passing the 21st Century Cures Act, Congress got to wondering why is it so hard to bend the cost curve? In particular, they wanted to understand why the EHR incentive program, better known as the MU program, which cost the federal government just under $50 billion, why it didn't do more to make data more widely available around the healthcare system. And when they started asking questions about this, they got a lot of testimony from developers and providers and others about the cost and difficulty of accessing provider data, especially data contained in EHRs. So an idea took hold that if these difficulties could be resolved somehow, competition could have some sort of effect on the growth of healthcare spending. So they went ahead, they passed the 21st Century Cures Act, at which point CMS began work on the payer version of the rules that would implement it, and ONC began work on the provider version of the rules that would implement it. Both of these aim to bring more competition to healthcare. They want to create the conditions in which consumers can make data-driven decisions about where to get their healthcare based on cost and the quality they can expect to receive. The idea is that consumers should be able to move around the healthcare system and choose, different providers. The data should be able to go with them rather than being marooned in the EHR of the last provider to see them. One theme that has, that's sort of emerged here is that apps, similar to the apps that consumers use all the time on their phones, should help patients in this, and that third-party developers should be able to access that patient data, assuming that the patient consents to it. So the focus on these rules is on patients is pretty clear, but it's not just patients who could or will benefit. The kind of API first approach basically will let developers build any kind of application for any user or any organization inside healthcare. In fact, the ONC version of this rule includes provisions that, at least in a theoretical sense, would allow providers to switch EHRs fairly easily. In terms of preparedness for complying with these rules, providers and the EHR vendors have been getting ready for several years. Every major EHR vendor offers or will soon offer the required version of FHIR. These requirements are similar in a lot of ways to just another stage in the MU process. Payers, on the other hand, are not quite as ready and will probably have slightly more difficulties in terms of coming into compliance. Although there's some pretty significant opportunities, and payers should not think of this as just something that they have to do because they're being told to by the government. So these rules only apply to CMS regulated payers. And what is a CMS regulated payer? It's Medicare Advantage, Medicaid. There's a bunch of other kind of categories of payer, but essentially they're the ones over which CMS exerts some kind of jurisdiction. The payer version of this rule has a very snappy name. It's called the Interoperability and Patient Access API rule. And there's a bunch of stuff that they've got to do, but these are the three main ones. The Patient Access API is going to look a lot like what already exists for Medicare fee-for-service beneficiaries in Blue Button 2.0. That's a FHIR-based set of REST APIs to member claims data. Payers are also going to have to provide current information about providers in their network, API accessible again. Slightly more problematic, the history of delivering and maintaining accurate provider directories hasn't been great. So I think this could be a challenge. The last major requirement is that plans have to make claims history available when members switch from plan to plan, so-called payer-to-payer data exchange. That's something that has really never been on any payer's radar, so this is kind of new and different. As I said, these only apply to the payers that CMS has some kind of supervisory control over, but there is strong interest from other private payers. In particular, employers want to be able to make these kinds of APIs available and usable by their employees. So employer plans would be wise to kind of get out in front of this and begin planning now. Employer plans also have the luxury of offering only the APIs that can make them more competitive in the market, like the patient access API or the provider directory API. They could ignore the more problematic elements like the member data portability. A lot could change over the next 6 months, 2 years, 3 years. The COVID pandemic has certainly injected uncertainty, along a lot of different dimensions for everybody. It would not be unthinkable that the implementation of these rules could be delayed or stretched out. We've already seen 1 6-month delay in some of the provisions. COVID has also kind of exposed problems with the public health system and public health reporting. And it's possible that a new administration could try to remedy this by hardening public health or standardizing public health reporting in some ways. 21st Century Cures Act also required, and I've kind of alluded to this, it required ONC to establish something, this national level network of networks, trusted exchange framework, and common agreement, TAFCA. The process of defining this network is ongoing, and it's led by an organization called the Sequoia Project, which also manages 2 existing national level network of networks, Care Equality and eHealth Exchange. In some theoretical sense, developers could subscribe to the TAFCA network and get access to patient or member data using FHIR APIs. But as it stands, that network is going to be based on IHE profiles involving document exchange. At this point, it is only looking at the possibility of building in FHIR support, but not going to be shocked if that is where we end up a year from now. Another aspect of TAFCA that could be interesting is the idea that it could support population level and broadcast queries, as in, give me all the records for diabetics in healthcare organization A, or give me all the records for member X, wherever those records are located around the United States. There's no current plan for either capability, but both ideas were in the original TAFCA proposal, and we could see those coming back at some point. Congress and the regulatory authorities here were heavily influenced by the wonders that have been wrought in consumer markets by downloadable apps from app stores. They really want to see consumers having access to useful apps that take advantage of all the health-related data that all these new APIs can provide. So APIs and API programs attract third-party developers who naturally want to attract new customers to use their apps. Many of those applications end up in app stores. And right now, it is almost only EHR vendors who have app stores. Every major EHR vendor has one already or will soon have one. The EHR vendors have a fairly rigorous process under which an app can be put on an app store. It usually involves functional testing, security testing, a bunch of things that essentially vet the app. A handful of large health systems have app stores, but these tend to be far more rudimentary than what you see from the EHR vendors. Now, when you look at what's available in those app stores, what you find is that most of those apps are for clinical or administrative users inside HCOs, not for patients. Most EHR vendors see app stores and apps as kind of a value add to their customer. They tend to do things that is not core to the EHR vendor. Content is a popular thing. It's not unusual for an app to appear in the App Store, and the EHR vendor is still going to require some additional level of process and testing before it can be turned on in the HCL. So an app appearing in an app store is not always the same thing as being a downloadable app. Apps and app stores can be really more reflect the vendor sort of larger partnership programs. Now, just to clarify, put a fine point on it. Every EHR app store has patient-facing apps, but the overwhelming majority of these apps are not meant for patients. Payers, which it sort of flies in the face of the intent of these new rules. Payers and health plans as a group don't sponsor app stores. Blue Button from CMS has an app store, and all of the apps in it are for patients or members, individuals. The largest category of apps on the Blue Button App Store is something where a member can use their claims to shop for Medicare Advantage plans, their historical claims to shop for Medicare Advantage plans. So, in any way, I really feel like with respect to app stores, we are probably in early days. It wouldn't be shocking to me if app stores kind of bifurcate into kind of two domains, consumer-facing and enterprise-facing. One sort of issue that's been floating around in the ether when it comes to app stores is who should be recommending to people what apps to use. And there's no simple answer to this. I kind of have an unusual feeling that at least in the early days, people are going to download apps that maybe a nurse recommends to them, but there's really no telling. At this point, it's hard to say who would be the most credible recommender. So a lot of different organizations are working hard to make FHIR and REST successful in healthcare. First and foremost are the EHR and HIT vendors as a group, and EHR vendors specifically. Most already have FHIR support of one kind or another, and most support REST APIs as part of their wider API programs. ONC has been a major FHIR and API booster for a long time. It's put together something called the FHIR at Scale Task Force. It had a different name previously, P2, I can't remember what that stands for. The idea there was to identify infrastructure level barriers to FHIR adoption and propose solutions. It is essentially trying to figure out reasons why FHIR might not be adopted widely enough to be successful in the market. And it's organized into a bunch of tiger teams that are shown here on this slide. I guess if I had to say who's the biggest booster of FHIR, I would say it was Health Level 7, which is the standards organization that brought us FHIR in the first place. It has a thing called the FHIR Accelerator Program, which I'm going to talk about in a little bit more detail on this next slide. I would be remiss, it's not on this slide, I would be remiss if I failed to mention IHE here. IHE is the organization called Integrating the Healthcare Enterprise. IHE profiles are a fixture of existing health information exchange workflows and applications, and IHE has been incorporating FHIR into its profiles and other resources for several years. Let's talk about the HL7's FHIR Accelerator programs. Most of these, this slide kind of shows a bunch of the different initiatives that they've kind of put together. Pretty much all of these initiatives, their work product is an implementation guide that's going to be based on the data element needs of developers and implementers for certain kinds of use cases. And I got to say that there's high interest in some of these use cases. The Argonaut project shows there on the upper left-hand side. That was put together by large providers and vendors back in 2014 when the industry essentially said to ONC, yeah, we're okay with the idea of APIs through something called the JSON Task Force. Argonaut is focused on implementations. Most people have heard by now about Smart on FHIR. It's a standard developed here in Boston at Boston Children's. It lets a patient, or any user really for that matter, authorize a third-party app to access their data. And it uses FHIR to express the scopes of that access, along with OAuth flows. FHIR bulk data access is another Argonaut project that came out of Boston Children's. It's the first serious attempt to enable data access at a population level, and it's going to let organizations exchange information about multiple individuals at one time. The implementation guide for FHIR bulk data access, as it stands right now, describes a FHIR-based approach to exporting data from a FHIR server to an authorized client or a service. At some point, I assume there's going to be an import version of that as well. Karen Alliance has also been around for a while. It focuses on what's called consumer-mediated exchange. That's where consumers allow third parties to access their healthcare data. Karen's got something called the Blue Button Framework. It's going to provide a uniform way for implementers to build applications in which consumers can authorize an app to access their claims data from a payer. And it lays out a set of data elements that are kind of consumer-oriented. And those data elements are modeled on CMS's Blue Button 2.0 Medicare API. In the Karen's Blue Button framework, that set of data elements is called the Common Payer Consumer Dataset, CPCDS. In 2018, HL7, some large provider organizations, a lot of national payers and blues, and some IT vendors organized something called the Da Vinci Project. The goal there is to leverage FHIR and establish standard ways to automate some of the more common use cases involved in payer and provider interactions for value-based arrangements. Gravity Project is looking at social risk factor data, especially how it's represented in different EHRs where it's all over the place, and trying to make that data so that it's interoperable and computable across different organizations. Project Vulcan, which was announced yesterday, quite literally, it aims to help healthcare researchers more effectively exchange and use data in translational and clinical research. And Codex focuses on representing data for cancer care and research. So in other words, there's quite a bit of work and resources available for people who want to build applications using FHIR. I'm sure 2, 3, 4 years down the road, there's going to be quite a bit more, but I really feel like at this point, the industry has got a running start. So at this point, I'm going to talk specifically about our report, which is kind of less about FHIR and APIs and more about what vendors are doing to make FHIR-based APIs and REST-based APIs useful to developers. So developers, as a group, are looking for kind of low friction technical access to data that they can use, and they're looking for access to a market in which they can prosper over the long term. And they want both of those under financial terms, that make sense to them. That, in other words, don't break the bank, that work for everybody. So they're looking to partner with organizations where they are most likely to get maximum access to data, the largest potential for new customers, and reasonable terms. So we looked at a bunch of different vendors and how and the extent to which they provide that. We also looked closely at the actual API portfolios and development resources of the vendors. And we looked at their REST APIs, we looked at their FHIR APIs. We also looked at their conventional APIs, things such as HL7, CCDA, IHE, et cetera, et cetera. I want to mention that APIs are used for literally a zillion different functions in development. Things like calculations, edits, formatting, application management. The list just goes on and on and on. This is about APIs that deliver live data. So all those other kinds of APIs are out of scope for this report. This slide describes kind of the organizational relationships and the participants in this market for discrete data APIs. On one side of the API, it's actually shown above here, are data holders. And that's typically going to be a hospital, a health system, a practice, a payer, a health plan, any organization involved in healthcare delivery or payment, or any organization who could conceivably contribute data to a healthcare application. Data holders have, they've got data use rights as well as the ability to kind of delegate those rights, typically under something like HIPAA. On one side, shown here on the right of the APIs, are developers who need kind of CRUD, create, read, update, and delete access to data in the holder's inventory. Developers use those APIs to build transactional applications for patients, for clinicians, administrators, any kind of user. They need access to data from a potentially really diverse set of applications and organizations. Between the data holder and the developer are vendors who build these APIs. They build a HIPAA compliant single source of or single place to get data along with related services for developers. So they build the APIs, they perform any backend integration needed to get access to the holder's data sources. For now, read access is really the primary way that APIs are kind of implemented and used, but most vendors also support some write interactions, and that is an area we expect to broaden as time goes by. So this is really like a data as a service type model, and it can support independent third-party developers. It can support developers who might be internal to the actual data holder itself. The hosting of data is where this data actually sits and lives is highly, highly variable. A lot of times the data holders are only comfortable they like to hold on to the data. In some cases, the vendors, what's shown here on the left-hand side, will host the data. It really kind of varies pretty dramatically across the board. REST and conventional web services are the predominant way that developers consume these APIs now. A little bit more, just a slightly different look at kind of the same thing here. This gives you some kind of idea of the diversity of data that exists. Data comes from a range of different organizations that operate inside healthcare. Inside each organization, data comes from a range of different applications and devices. No single vendor in this market can provide access to data. All organizations and venues, all applications, and all devices. Every vendor in this report provides API-based access to some organizations, some applications, and some devices. So the developer is left with trying to figure out which vendors it really needs to partner with in order to get to the organizations, application sources, and device sources that it needs. We looked at 50 or so vendors over the course of probably 3 years to develop this report. We ended up profiling 20. And they fall into a bunch of different categories. EHR vendors are really important in this market. For developers, they are often the first and last stop when it comes to getting access to data. Developers are more likely to get access to the particular constellation of organizations, applications, and devices that, to support their business from EHR vendors than from any other single category. What we are calling here healthcare API vendors are the alternative to EHR vendors. They provide, for the most part, pure REST-based access to mostly EHR, but also rev cycle and practice management data. Their primary advantage over EHR vendors is cross-organization consistency. With EHR vendors, no matter what kind of API you're using from an EHR vendor, whether it's FHIR, HL7, IHE, X12, the vendor's native APIs, there's going to be some variability across the EHR vendor's customers, and that variability can be significant. Healthcare API vendors deliver a consistently expressed, consistently formatted response to API calls across different organizations. Now, independent developers value this because they don't have to reintegrate and re-implement for each organization that they connect it to. Even EHR vendors, FHIR APIs, suffer from this problem to some extent, but to a lesser degree than its other APIs. What we're calling device data integrators is a little bit of wishful thinking on my part, to be perfectly honest. But there's a staggering volume of data that flows from hospitals, clinics, homes, and from wearables, a true mountain of data. Most device manufacturers provide some kind of standalone application or point integrations that use this data in some sort of application context. And as a group, they have not been enthusiastic about supporting developers, except for a handful of newer companies that we profile in this report. We've got Human API and Validic. Orders and results clearinghouses are similarly a little bit of wishful thinking here, because they, as a rule, don't embrace developers and developer support all that aggressively, but they conduct an extremely large volume of transactions between labs and imaging centers and others, usually ambulatory providers, but also with payers, using conventional techniques. Claims clearinghouses are kind of in the same category. They participate in X12-based transactions between providers and payers. A very small number are beginning to offer REST API-based versions of some of their more common transactions. But APIs would essentially represent a form of channel conflict to them. In other words, if it were relatively easy and cheap to integrate with them using APIs, their existing X12 business would suffer. Interestingly, some of the healthcare API vendors in this report, the two categories up, they offer payment and revenue-oriented transactions through REST APIs that are a very clear alternative to what claims clearinghouses traditionally do. Patient-focused vendors is a category we expect to grow. They specialize in APIs that provide access to the single patient or member's data, usually for developers of downloadable patient or member-facing apps. This slide kind of summarizes our high-level conclusions about the different vendor categories. On the x-axis here, what's called developer readiness, we looked at the depth and comprehensiveness of the vendor's API and developer support programs, its partnership programs, the use cases and organizations that the vendor targets and attracts in terms of developers. On the y-axis, which we've called the proximity and variety of data sources, we looked at the diversity of original data sources provided by the APIs, both from organizations and from medical devices. An important consideration here is the vendor's proximity to the data holder, as well as the variety of organization and device types. This y-axis, gives you some idea of the likelihood that a developer is going to find the scope of data it's looking for if it partners with that vendor. Each point here is essentially the average of the vendors on this previous slide. The first column there is the vendor type. Second column is profiled vendors. We average the scores of the profiled vendors to get this particular slide right here. A couple of notes on this. From a developer support perspective, healthcare API vendors do pretty well here. These companies, for the most part, are true API first companies in the Silicon Valley sense of that word. They are very attentive to the needs of independent developers. The other two categories that do well in this they're also API first in their approach, but I do have to mention that device data integrators, the two device data integrators who are in this report, are completely unrepresentative of device data integrators generally. Now, the other thing that kind of jumps out about this chart is that EHR vendors I mentioned earlier that EHR vendors are often the first and last stop for developers. They have access to the most data and the most varied types of data. EHR vendors as a group, they're installed in, as the name implies, in every single healthcare organization in one way, shape, or form. The scope of data that's available from all of these other categories is much narrower than what's available from the EHR vendors. So at this point, that kind of concludes everything that I had planned to say. So we'd like to open this up to questions.
Okay, so the first question that we have is, what are some of the revenue models for accessing APIs? How are people monetizing their development platforms?
Revenue models are pretty variable. As a kind of a general observation across IT and the whole API ecosystem, metered usage is really, really common, and and that is essentially a charge associated with each get, put, post, delete API call. You see that here in healthcare, but as a rule, it's kind of less common. The advantage of that approach is it's really simple to administer. It's really simple to understand. It's really simple to put tiered pricing plans together. If I had to generalize, I'd say the EHR vendors, I think for the most part, it's kind of built into the price. So it appears to be free. It's not at all clear that it is actually free. When you look at vendors who live on these things, it's fairly common for them to charge based on the number of organizations that your application gets deployed into. And then there are various kinds of hybrid plans as well. So I do feel like, we're heading in the direction of, per call pricing. The simplicity of it is kind of a siren song. But I think the real value to developers is number of organizations. So I guess if per call simple, number of organizations is really more value oriented. So that could point to the long term, over the long term.
Okay, great. Thanks, Brian. So the next question is asking, as a developer, which platform could most easily access APIs at this time if they are building an app? I.e., what is the most open platform?
So this is, open's not an entirely clear term, but every vendor that we've got in this report has publicly available API documentation that anybody can kind of sign up and read. Now, sometimes you need to sort of, give them your email address, and you have to wait a couple of days to get a token or something so you can access it. But as a rule, the information about APIs is pretty available, and over time, I think is going to become a lot more available. The next set of issues that I think most developers are interested in is what kind of support resources are there for people who are building applications. And that's where, quite honestly, a lot of these vendors really, things really begin to be a lot less standard. I talked about the healthcare API vendors who are, as a group here, truly API first. I mean, their only customer is developers. They provide a lot of resources that most of the other vendor categories don't provide. You've got Slack channels, you've got various different sandboxes. So there's, I think the real question is the support is more about the support resources than it is about the APIs themselves.
Okay, so the next question is looking at, outside of the clinical setting, what's going on with kind of the interoperability rules and what the other organizations are doing, specifically pharmacies and PBMs, and the difficulties that payers may be facing.
So let's talk about pharmacies and PCMs. One of the vendors, and there's air quotes around that, in this report is NCPDP, which is really an intermediary. You need to kind of go through them in order to fill a script in the United States. I don't think the pharmacies and PBMs are necessarily jumping on this. I think that they will eventually have to jump on it. It is conceivable that they could be, one of the things that nobody's really talked about is how heavily they could be regulated under these rules. And they are, to the extent they are something called a health information network, then there could be some reason there should be some scrutiny on how they operate. But APIs are not part of their plans, as far as I can tell. Payers, on the other hand, obviously all the CMS regulated payers are going to have to build the set of APIs I talked about in this presentation. That will model, I mean, they are going to be a model for the rest of payers. So I really feel like payers, even though they have not paid close attention to this topic, they paid far less attention to this topic than providers have as a group. I feel like they're going to be making some progress fairly quickly.
Okay. What about public cloud vendors? How are they getting involved in this or enabling this type of functionality from their perspective? So like the AWS or Azores?
Well, the public cloud vendors have really significant facilities for developers. I mean, every single one of them is there to help developers build applications. What they can't do is provide access to data. Now, what we're seeing a little bit more often is that some of the vendors in this report will host their APIs on one of those public cloud vendors. So for example, you can get to Change Healthcare is one of the vendors we talked about. All of their APIs you can buy through AWS. I feel like that's going to become more common, and it wouldn't surprise me if some of the public cloud vendors are a little bit more aggressive about recruiting vendors who can enable this sort of data access through APIs over time.
Do you foresee an eventual release of a DNS-like service for API directory discovery? This one person mentions Project Lantern. I don't know if you're familiar with that, but yeah. So how do you go about doing the API directory discovery?
So endpoint discovery is, so it's a little bit in the weeds, but it's critically important. I am aware that there are a number of different organizations and initiatives that are looking at this for particular kinds of use cases. I can't rattle off the specifics of Lantern on the top of my head, but this question raises a critically important issue, critically important infrastructure issue, and I know that it is not being ignored.
Okay. I guess the final question then is, are there regulatory efforts in progress to improve the availability of device data specifically?
I think device data is, if there's any kind of data category here that is lagging, I would say it is device data generally. Now, it's also certainly true that not everybody needs access to device data all the time. And it is certainly true that most of the device manufacturers do a reasonable job of getting their data where it's needed, at least in the here and now. But I'm not sure, devices are regulated by the federal government in a slightly different way than all the other organizations we kind of touched on today. They have significant representation by lobbyists in Washington, D.C., who resist expensive change. But, I feel like it's an underrepresented category of data, and one that would benefit immensely from better API-based access.
Okay, so that is all of the audience submitted questions for today. So without further ado, I would like to share a couple of announcements from the team here at chlmrk. First off, we have another API-based webinar coming up at the beginning of September, and this is building off of our COVID Lessons Learned series. So we're talking with different vendors that have enough market penetration and customers to really have a good high-level view of what's going on in the market. And so these folks will be joining us to share what they've learned from working with their clients through the COVID pandemic, and kind of evaluating how APIs are being used and what their future might hold as as the healthcare system changes to adapt to the future of additional pandemics. So that will be September 9th at 1 p.m. Eastern Time, and we'll be joined by executives from Change Healthcare, Lineate, and Datica. This one will also be moderated by Brian. And then tomorrow, we'll actually be releasing our first revenue integrity market trends report. And this will be looking at how revenue integrity has been shifting to accommodate what's going on with healthcare economics and the money that providers can be either saving or earning through better revenue integrity solutions. So thank you everyone for joining us today and taking the time out of your afternoon to attend this webinar. We will send out slides and the recording as soon as they are available, which will likely be before Friday. So be on the lookout for that. And if you have any follow-up questions, feel free to reach out to myself or Brian directly, and we can coordinate a call or just answer it via email. Thank you for your time, and I look forward to seeing you guys at a future webinar.